Now we move on to the next talk on endophthalmitis. Dr. Abhishek Kothari is a VR surgeon from Jaipur, and he'll be speaking on this topic.
So I'd like to thank Dr. Reyes for including me in his IC, and I'd like to thank all of you for coming here on the final day and listening to us yap on. So this is something that all VR surgeons have to face, endophthalmitis. And a lot of our endophthalmitis doesn't come to us when it's in the beginning phase where you can manage with injection or a simple core vitrectomy. Sometimes it is quite fulminant. It's basically an SOS from the eye. I have no financial conflicts to declare. Now, what is fulminant endophthalmitis? It is that which is severe and rapidly progressing, either because of the virulence of the strain or because the organism is unusual and you're unable to, put a finger on and use the correct antibiotic. A lot of times with trauma and even with post-operative endophthalmitis, it is polymicrobial, and you get a result of one of the organisms, and you start treating along those lines and forget the other organism. Sometimes with the compromised immunity and drug abuse, sometimes in neonates, you get really bad endophthalmitis. We've all heard about, the post-Avastin counterfeit injections causing endophthalmitis, and these were really bad ones. And sometimes with traditional surgeries with large wounds, you get fulminant endophthalmitis. Now, before we go on how to manage it, first, let us look at the reasons why you get poor outcomes in these cases. If you have a highly virulent organism or drug resistance, then your job becomes difficult. If you have a late presentation or a delayed diagnosis, or you are not using specialist support or appropriate instrumentation or even diagnostics, you may have a delay in instituting the exact antibiotics. A lot of times, inadequate drug concentrations or control of inflammation causes more damage than the organism itself. And sometimes the complications that are left untreated at the time of surgery, for example, a retinal break or large ERM, that can cause problems. So the aims of treatment are to sterilize the eye, to control the inflammation in this order. Sterilize the eye first, control the inflammation, and then address the comorbidities. Now, sterilizing the eye, it's best to know what you want to hit. So vitreous biopsy is always essential, and routine microbiology sometimes does not give us the answer. So I would strongly encourage people, whenever you have a severe endophthalmitis, jump quickly to PCR techniques because their sensitivity is much better than the routine microbiology. Always we order both. It's not that we do only PCR or only routine microbiology. Also, antibiotics, we use vancomycin and ceftazidime as a routine in all our cases, and ampho-B at the first go. But if it's a severe endophthalmitis and it's been treated earlier with these, have a very small, I would say, threshold to escalate. And how do you escalate? For gram-positive, you go to linezolid. It's a very, very effective antibiotic. For gram-negative, go to either piperacillin tazobactam, or my choice is colistin. And for fungal, you either go to voriconazole or caspofungin. So antibiotic escalation should happen early on if you don't get the response that you desire. Surgery, again, early, not according to EVS. If the media permits, if you have severe inflammation, if you have an increasing trend, or if the comorbidity like a foreign body or something like that dictates it, go for early surgery. You usually defer it only when you cannot do it. That is media opacity, you may have choroidals or some systemic factors. If you cannot do it, then wait. Otherwise, most of the times I would jump in. Controlling the inflammation is very, very, very important because sterilization is not alone responsible, to give you a good outcome. Macular edema, membranes, retinal detachment, and hypotony, all of them can result from inflammation. And vitreous acts as a reservoir for inflammatory mediators. So that's how early vitrectomy helps. I always induce a PVD. It's a controversial thing, but I almost always induce a PVD if I go in. And I use systemic and intravitreal steroids very frequently. Now, this is a very nice case. It has endophthalmitis with a foreign body impacted right next to the disc. So let me run this video. So this is what we usually do. The view is not almost always as great as you would have in a routine case. Most of the vitreous is cleared actually, and I'm running it from the point where you can actually see things. So don't be afraid. The problem with endovitrectomy is you cannot identify landmarks that easily. Sometimes what you think is a membrane may turn out to be retina, and what you sometimes think as retina may turn out to be a membrane. So you have to be very careful. Always have that orientation in mind, whether you're operating on the right eye or the left eye, and make sure you go along the routine expected landmarks. Collections of purulent material can sometimes appear as disc, and you may make mistakes. So here is we've reached the disc. All the vessels are basically sheathed, and there is collection. So I'm very slowly trying to peel and cut and peel and cut, and then I reach the disc. Once the disc landmarks are visible, very, very gradually, not like a routine PVD, holding it and just pulling it up. We do it a little more gradual fashion and along the retina. And my routine technique in severe endophthalmitis is to at least take the PVD till outside the arcade. I do not want to do it till the mid-periphery or to the periphery, just sufficient to, clear the posterior pole. Now in this case, there was also a foreign body impacted right under this. You see that hemorrhagic blob there, and of course you have to take the foreign body out. So initially I thought it's just the foreign body impacted there, and to remove it, I started inducing the PVD, and then I had a retinal break. Now this is the video that I'm trying to show. See, there's a retinal break and there's a bleed close to the disc. So this is something that, most of us would be really scared. And the reason I'm showing this video will become apparent to you. I still do continue doing things the way I would. One of the important things that I would like to stress in my talk is do not try to do everything in one go. You can sometimes do things in a sequential manner also. So here I've basically cleared up all the vitreous. At this point of time, I've not found the foreign body. I tried scratching it with the tip of my cutter. So then I start exploring. It's there in the peripheral vitreous. So that was basically a ricocheted foreign body, which had created the break near the disc and then gone back. So this is the foreign body here in the inferior periphery. So this is also something which is difficult to sometimes locate in foreign bodies with endoph because of the peripheral thick white opaque skirt with all the inflammation and fibrin. You sometimes can't find the foreign body. By the way, this is a phakic patient. So I'm using basically a handshake technique to take out this foreign body. And this is the end of surgery. I fill it up with oil. I do not want to do laser at this point. There is subretinal heme. So I will end up lasering a much larger area. So I fill it up with oil, treat it with postoperative intravitreals, dry out the inflammation and the infection. And this is how it progresses over time. With the oil, there's not going to be a detachment early on. After some time, you find that it is scarred, and then at that time, I go ahead and do off a laser, and then remove the oil later. And this patient is doing very well. This patient is 6'9". This is another of my favorite things that I do even in routine endos like postoperative endos when there is severe inflammation. You may have done a core vitrectomy, but the very next day or 2 days later, you still see that the media is mucky and you can't see much. So I do a 2-port lavage. This is a gravity-fed infusion in a routine IV line. The infusion goes in through a 24-gauge needle, and I just hold a 26-gauge needle at the opposite pars plana and let it drain for about 2-3 minutes. So this is basically to remove all the massive amount of inflammatory mediators. So this clears up the media very fast. At the end of this, I leave antibiotics in the eye. Anyway, I'm taking the patient after 48 hours into the OT to give them antibiotic injection. So I rather do a lavage and clear off the media to the extent possible. Sometimes you have to handle comorbidities like corneal issues, foreign bodies, etc. And one of the worst is the corneal issues. Sometimes you may have a wound that requires suturing. Sometimes you may have edema or infiltration or opacity. And in these eyes, sometimes we use a K-Pro. So this is a video of a patient who, again, a one-eyed patient who has a corneal opacity, or rather I would say infiltration, along with foreign body, RD, and endoph. So this is basically trephining the cornea, and then we put a temporary keratoprosthesis. For want of time, I will just fast forward it. This is a temporary keratoprosthesis, Landers. They come in both irrigating and non-irrigating varieties. You first put this on, and this gives you a fantastic view of the posterior. Then we start peeling off the membranes. This is all the organized vitreous that is there. This is taken care of, all the vitreous is removed, and then you can start seeing the retina. There is that foreign body lying there. The foreign body is also removed, and once all this is done, then that was the foreign body being removed, and then you fill in oil, and at the end, you use the donor cornea to put this, to seal this eye back again. Now, we almost always expect this cornea to fail, so you can do this with a grade B cornea. You don't need a very good cornea for this, because at the time of SOR, you usually will want to or will have to replace this with a better cornea. A lot of people, advocate complete extensive vitrectomy, and they say that it reduces the microbial load, it improves antibiotic excess, gives better kill, and the substrate for bacterial growth is removed. The math, if you look at it, even if you remove a lot of organisms and just leave 1 million organisms that is smaller than a pin tip, at the end of just 24 hours, when you see the patient again, there will be 1 billion organisms per ml. So you really, if you think that you're doing a vitrectomy to reduce the number of microorganisms, it's absolutely wrong. And oil or no oil, a lot of people in fulminant endophthalmitis put in oil at the end of surgery. If you have an indication, put oil. If you think that it is antibacterial, it prevents detachment, or it gives media clarity, no. These are not the indications where you should be using oil, because we've done an experiment where we created wells of agar similar to the size of the eye and filled them with silicone oil and put in the microorganisms, and they grew very well under the oil. See, this is Staphylococcus aureus, gram-negative organism. You can see the growth under the oil, and this is Candida. It grows fantastically under oil. So don't think that oil is going to stop anything from growing. Again, if you've created a break, oil is not going to prevent a detachment. You'll have to treat the break, otherwise the detachment is going to happen. So these notions, please leave it out of your head, that the worst thing that oil can do is all your inflammatory mediators will be outside the oil, that thin film, which will now hit the ciliary body and the anterior segment and will complicate your efforts in the long run. It can cause hypotony also. So put in oil only when it is required. And by the way, when you put in oil, then all your calculations of antibiotic and toxicity also go for a 6. You really don't know how much is the fluid compartment below it, and it's very difficult to handle. Multiple surgeries, this is my last slide. So multiple surgeries is something that I advocate in any bad situation, even in non-end-off cases. Sometimes you cannot achieve all your surgical objectives in one sitting. So whatever you can, do it. Maybe 3 days later, 4 days later, 5 days later, when the inflammation and the infection has subsided, you can go ahead and do the complete surgery. It helps in the way that you have a better view, lesser inflammation, and a more calm mind. Thank you so much.
Thank you. Any questions? I think Sir is wanting to say something, and even we are, I think, wanting to say the same things.
Well, few more things I would like to add. We have done a thesis on endophthalmitis, early vitrectomy, and what our results were, the earliest, the better.
Yes.
EVS study was done 30 years ago on cataract patients. The results cannot be extrapolated to all cases of endophthalmitis. Never, I should say.
Quite correct.
And secondly, so as Dr. Abhishek sir has shown, doing a PVD, inducing a PVD is very good, and the picture that we are seeing from the anterior segment, from the slit lamp, after removing the PVD, it might be a very good picture, and it might be, I should say, like anything, especially if it's our own case. And one more thing is, sir, you had yourself put an oil in a case. I think you were, in the case that you had induced a...
Yeah, because there was a break.
There was a break. Sir,
Yes.
why not PFCL?
Why PFCL? I mean, there is a break. I want to leave it for long.
Instantly it would prevent the bleed further. You can complete your surgery.
All bleeds stop. All bleeds stop. If we always do a PT, APTT, and a BTCT. So all bleeds stop. Very few bleeds
It's an inflamed
continue.
retina, sir.
Yeah, it's an inflamed retina. So the only problem that has been, talked about after leaving PFCL is inflammation. So I don't want to leave something that can possibly cause inflammation in an already inflamed eye.
Achha.
So there is a break. I would want to leave the tamponade for long because I want the subretinal blood to go away. I want it to fibrose and and become shrunken to one small area that I can laser.
So the patient will
Prone.
prone.
Okay.
I think the main indication for PFCL in all these cases are recurrent inferior RD, where a patient can't position in a prone fashion. That should be one of the only indications for using PFCL as a endotampered long term, because it is not approved also. This is something
Not long term, sir. I'm speaking about the peroperative.
I
think when you had
just
the
for
bleed,
the intraoperatively
just to
you
stop
can
the
use it.
bleed,
Yeah,
you
at that point is fine. But Dr. Abhishek
Yeah, so
understood your
if
question
it-
that you want to leave PFCL.
If the bleed had not stopped, I would have considered it. The bleed stopped.
I think he misunderstood. He thought you were asking that why did you not inject the oil with PFCL and leave it like that, close the eye with PFCL in it.
So here the bleed stopped and the retina is not detached.
And
So-
one more thing is, as Dr. Abhishek has told, that the silicon globule is there, and if the patient is erect, all the microbial load is inferiorly. If the patient is lying supine, it's close to the macula, and if it's lying this side, it's here, and the central portion is saved, and all the organisms, the load and the inflammatory material and everything, the toxins, they are actually circulating very close to the retina, actually in touch contact with the retina.
So there are
Silicon,
there are
and
MRI
in that
studies.
case, the eye was lost, and the
No,
patient
I-
will be presented, we had scleral necrosis.
We have used, and I think this is good that you've shown, but if you do literature search, there are actual publications in retina. There's a publication EGO, and they have shown that it has antimicrobial, and these are standard publications in retina journal. So I think we have to have a balanced view because this is an instruction course. But
So I'll tell you
this
what.
is his
So what
experience.
happens with oil is that there are MRI studies on RD patients, not even end-off patients, where they've estimated the amount of oil after a retinal surgery, and the fluid compartment. So it varies from 0.2 to almost 1.5 cc. And these are cases where you had clear visualization. End of visualization low, how much you are going to fill, how much is going to be residual, you really don't know. And after that, when you start putting in the antibiotics, you have no idea as to what the final concentration is going to be.
I think Dr. Dhaneshi can come on to and put up her slides, and we can continue the discussion after the. Okay, while ma'am is putting up her presentation, we can have one or two questions. Abhishek can come and be on the panel.
What is the role of systemic antibiotic in this?
So this is a very good question, because when the EVS study was published, those antibiotics which were, I think we discussed in that other thing also, antibiotics used did not have good intraocular penetration. But what you have to remember now, moxifloxacin has very good penetration, intraocular penetration. So what we do is we start the patient on moxifloxacin 400 milligram BD, these end-of patients. And I mean, we've not done any clinical trial, but we feel it helps. And it is known that it's much better than using the oral antibiotics.
So linezolid is an antibiotic that even in non-inflamed conditions, one single oral dose reaches the reaches concentrations of more than MIC 90 for most of the gram-positive organisms. So it works. Even for MRSA. So that is only for gram-positive though. And ciprofloxacin also penetrates. Voriconazole via the oral route does reach into significant amounts in the eye. So those are the three you can use orally.
Choice of antibiotic for traumatic endo.